Hi, everyone. My name is Dr. Esiosa Adaro, and today I'm going to be talking about admissions for the stroke service. Currently a PGY4 at Mayo Clinic, and I'm creating these videos for my junior residents, but they can be used for a lot of other residents at other institutions who are trying to get organized and be more efficient on the inpatient services. So here's a checklist that I developed when I was a junior resident on stroke that helped me to keep my workflow in order so that I don't miss things. So these are what I expect my junior residents to do when they're on the stroke service. In my last video, I talked about the workflow with respect to pre-rounding, rounds, and post rounds. So that is in my first video. So make sure you check it out on my YouTube channel. And we're going to be talking about admissions. And in a later video, I'll talk about discharge. So what to do when a patient gets admitted to the floor service, or at least at our institution at Mayo Clinic, the guideline is as soon as the patient hits the floor and the on-call resident gets the page, see that patient within less than 5 minutes from when they hit the floor. This is extremely important because you want to get the neurological exam as soon as they hit the floor so that you have a baseline. And will also be seeing the patient with you so that I, myself as a senior resident, have a baseline. When you're in the patient room, two big things you want to get along with the history of present illness, what happened in the ED, etc., is you want to get their you want to get a med rec, which is the medication reconciliation. And so what I do before I see the patient, when I know the patient's coming to the floor, I go into the chart, and if there's a home med list, I print that out so that when I go into the room, I can confirm with the patient. And I also get the code status. That's extremely important. We need that entered into the orders when the patient is admitted. So two biggest things you must get is the med rec and the code status. And at times, because we're on a stroke service, the patient may not be able to speak. They may have dysarthria to where you can't understand them, or they may have aphasia to where they're not able to communicate. Therefore, with these two items, you can see if a family member is in the room, get the information from them, see if they have an advanced care directive where they talk about code status. You can also talk to our pharmacists if they're on the floor, and they can assist in getting the med rec if the patient is not able to give it, and if there's not a family member around or a family member that you can call to get this information. And then what's expected as well is when you're seeing the patient, after you get this information, then you want to take the detailed history more so than what was obtained in the emergency room. And you want to be sure that you fully understand what brought the patient into the hospital before they came. Because you as a junior resident, you are expected to know the patient the best and have as much of an accurate history as you can possibly obtain, and talking with the patient, talking with the family, and also doing chart review. After you've gotten the information, you do the NIH Stroke Scale. Then you come back, and maybe I should include this here so that it's a reminder. So you want to do the NIH Stroke Scale. You want to collect the HPI. And then you can do chart review to get the other pertinent information, such as the ED course, images, vitals, and what the emergency neurology resident stroke scale got, because you also will be getting sign out from the ED senior. I'll just put that here. There, so I've updated my checklist. So you'll get sign out from the ED senior before the patient hits the floor. And as you're getting sign out, you can stub your H&P note, and then also start chart reviewing. And with the chart review, it's important to know what the emergency room course is, looking at the imagings and the labs. And then after you get signed up from the senior, then the patient can arrive to the floor within minutes or hours, and you'll get a page on when the patient hits the floor. And we already talked about these items here. So once you've gotten this information, now you come back to your computer and you admit the patient officially into the stroke service. This is really important. As soon as you come back to the room, we need to start having these orders placed. So, and I'll walk you through how to do this for your first time. There's an admission order that you have to use so that the patient can be admitted to our service. And after you place the admission order, then we have a stroke admission order set that's specific to patients on the stroke service that includes pertinent information from our standpoint, especially with nursing cares and NIH Stroke Scales, how often to do it, consulting PMR, PT, OT, speech if needed, etc. So I'll walk you through how to use this stroke admission set in person. Along with that, after you place the stroke admission set, the next thing you should place is medications. Biggest medications we need to place on stroke is what's their antiplatelet plan? Do they need anticoagulation if they have AFib or other indications for anticoagulation? Are they on any antihypertensive medications at home? If so, what's the plan for restarting that? Usually, if a patient presents with an acute stroke, we want to allow permissive hypertension for at least 24 hours. Then the day after, we're going to be wanting to restart their meds. So as long as we look at their meds and make sure we're not forgetting any medications that need to be started. At times, patient will come in with blood pressures in the 250s. So at times, we'll need to do PRN medications. So we just need to make sure we're addressing anti-hypertension plan. And certain medications we cannot hold, such as individuals that have atrial fibrillation. It's important to keep their rate controlled medication and rhythm controlled medications on board. Some of these medications tend to be also hypertensive medications. So we will restart, for example, their metoprolol maybe at a half dose, not the full dose, so that the patient doesn't go into AFib with RBR. So it's really key that you talk to me and we make sure we place orders for these important medications so they don't get missed. After you insert all of the important medications, then you need to enter in the labs any imagings that we discussed in any consults. For example, at times we'll have a patient that may have a chronic internal carotid stenosis. So that means neurosurgery will need to see them to see if the patient is a candidate for a stent or CEA. So that'll be an order that we would want to place when they're admitted. Other things, for example, if an MRI wasn't done in the emergency room and we want to see if the patient actually had a stroke, then we want to place an MRI brain DWI sequence. Those are things you want to place when the patient is hits the floor. Other things would be if a patient comes and we're concerned for cardioembolic stroke, we'll need to place some kind of cardiac imaging, whether it's cardiac imaging, whether it's a TTE versus a TEE versus cardiac CT, we can have that discussion and place the appropriate order so that we can expedite patient care. Here at labs, if the stroke labs weren't done in the ED, then we'll need to place it when they hit the floor so that the patient gets the labs done on time and we can help with secondary stroke prevention. After you've completed this, then that's when you want to start finishing your admission note. And remember, you stubbed it already. You hopefully have done some chart review, so it'll help expedite the process. And now you just got to fill in other parts of the admission note, as I discussed in my previous video. And it's important, at least at our hospital, when you write the admission note, there is a stroke template that was sent out by the chiefs, and we expect all of the junior residents to use that because it has all the pertinent information that needs to be included in a patient who's on the stroke service, and it just makes your lives much easier. A very important thing to include in all patients who are admitted for stroke is the stroke dot phrase. It's basically a form that we fill out that we insert at the bottom of the note. And this is what our Stroke Joint Commission uses to pull data so that they are compliant with the Stroke Joint Commission so that we can continue our certification as a comprehensive stroke center. And again, I'll show you how to do a lot of these tasks above, but I just wanted to give you a checklist so that once I show you how to do it, you can continue doing it and not miss things. Lastly, once you've written your admission note, handoff needs to be updated by 5:30. Really, really try your best to update the handoffs. Now, if a patient comes to the floor at 6, that's a different story. But if a patient comes way before 5:30, all handoffs need to be updated on every patient by 5:30 so that I have time to review it before the on-call resident comes. And then hospital courses, even for patients who are newly admitted, you can take what you've written in your HPI and copy and paste that into the hospital course so that we can keep updating the hospital course every day so that it's not left to the last day when the patient's discharged and it takes a lot more time. So aim to complete your hospital course by 6 p.m. For newly admitted patients, it's going to be very quick because you just copy and paste your HPI. So with that is the workflow for admitting patients onto our stroke service. And if you have questions, let me know. You can always refer to this every time you have an admission, just come back, review this video, and eventually you have everything down. And it's always extremely important, especially on extremely busy services, to have your system have a checklist. So what I would do is I would print this off, and I'll send you a document for this. I would print this off. Every time I had an admission, I would just go down my checklist. And it really helped with my workflow. And I noted I wasn't missing things anymore as a junior resident. And I was, able to, I was able to attend to more items and higher level thinking because I had my checklist and I knew the basics and the fundamentals have been taken care of for the patient. I look forward to seeing you all on soon. And if you have questions, let me know. Other things I want to just highlight are this book called The Acute Neurology Survival Guide. This book takes checklists for the inpatient services to the next level. Is written by Dr. Albin, who I know well at Emory, and another one of her colleagues who is at Harvard. And this book is important for especially junior residents who are going into neurology. I strongly recommend getting yourself a copy of this book because it really goes through, how to pre-round, how to present patients, how to present patients on the neurology floor, how to present patients in the neuro ICU floor, coma exam, cranial nerve testing. It also has a really great chapter on stroke and vascular anatomy, how to read CT scans, MRI, TCDs. It's just an extremely helpful book. I wish I had this when I was a junior resident, but it wasn't available. But it would have definitely been very useful had I had it. So I strongly recommend getting this book, and I'll put a link in I will put a link for this book in the YouTube video comment section. And for those off-service residents, I have a copy of this book that I'll bring to work so that you can use it and review it for your duration while you're on the stroke service. And if you would like to supplement your education, I strongly recommend that you take a look at my YouTube channel where I have posted numerous videos that talk about all things neurology. For the individuals on the stroke service, I have about 4 or 5 videos, and you can see them here, where I talk about stroke cases, and I go through numerous stroke cases, and we talk about the presentation, stroke scale, imaging, anticoagulation, antiplatelet plan, etc. So if you have time, I strongly encourage you to take a look at some of these videos, and it will help with understanding why we do what we do. With that, I will end the video, and if you have questions, you can comment on my YouTube channel. For those of you that are working with me, feel free to reach out, and I will see you all at the next video. Have a great day.